So what I did was I kept her on dual antiplatelet drugs because initially for the 1 year she was doing very well with ticagrelor and aspirin. So I thought she would do the same. So I kept her on DAPT with ticagrelor and I continued her on medical management. So, but unfortunately, 6 months later, she came with the acute coronary syndrome. That was in May. So I did an angiogram, and this is the finding in angiogram. So she has a thrombotic lesions in the LAD, multiple thrombotic lesions in the LAD, in the circumflex, but the RCA is flowing well. Although I know that RCA also has a malapose stent. So and angiographically RCA is patent. So how do we go about now? So I thought I discussed with the patient's family, since there's a multiple vessels involved, possibly a kind of hypersensitivity reaction with the. So I decided that I should send her for bypass surgery, which will probably tackle the entire issue of all the vessels. So they agreed, and so I then told the surgeon, you should graft all the vessels, including the right coronary artery, though it is a patent and flowing vessel. The surgeons, this was a plan, but however, the surgeons grafted the LAD and the OM. So she underwent bypass, but the surgeons grafted the LAD and the circumflex. But despite me telling them, they were not keen to graft the right coronary artery. You know, surgeons always want to go by the angiogram. And the two grafts were placed, and she was doing well. So I was happy. Anyway, the RC was not grafted, but still I was quite happy. So patient was kept on aspirin and ticagrelor. She was doing well for 6 months. And 6 months later, she comes back again, this time again with unstable angina. What is this? Is it a graft issue? Or is it something to do with the RCA? Or is it a distal embolization of thrombus into the LAD and circumflex? So what is this? So we decided that we should do an angiogram again. And we did the angiogram. And as you can see here, the grafts, the patent grafts, the lima was flowing well, and both the Y grafts to lima and the OM were patent very well. So next is to check whether the right coronary artery is giving a problem. So we did decide to look at the right coronary artery. Exactly, we had again at the stented segment, this time a significant narrowing in the stented segment. So what is this? Is this stent thrombosis? I think from the previous OCT imaging, we know that it could be stent thrombosis. So definitely we need to image this again. So we did imaging again, and this was the IVUS. Again, you could see that there is a positive remodeling of the right coronary artery, which is better seen here, as well as there is thrombus in that area, the vessel behind the stent. So you could see that there is a thrombus, the entire part of the stent, the mid stent, the distal edge, and also in the proximal. So how do we treat now? We already exhausted the option of bypass surgery. So as Dr. Selvamani said, should we consider something like a covered stent or bioabsorbable BRS, or should we re-stent it again, or should we keep on long-term anticoagulation like Dr. Seth said, or should we thrombolize now, or redo CABG? So I think we'll have a small discussion, and then I will say what would you do? Let me proceed. So what I did was I decided that I discussed all options, and I thought probably we could not use another drug-eluting stent. And I was thinking whether a bare metal stent, at that time the bare metal stent was available, and I thought whether I should post-dilate to the maximum and get a bare metal stent inside. So I did post-dilate with a larger balloon and try to oppose as much as possible. And then I put in a bare metal stent. That time is a vision stent which we deployed. And this was the IVUS. You could see that we could get a maximum amount of apposition with the post-stenting and post-dilatation again. Possibly there could be some thrombus behind the stent, but we did maximum possible to post-dilate it as much as possible. And this was the angiographic result after we stented. And I think, okay, we got a good angiographic result. So then this time, fortunately, after 6 months, we were waiting whether the patient would come back, but she didn't come back. We called her after 9 months and said, come, maybe let's do an angiogram, a check angiogram to see what's happening. So we did a check angiogram, and we found a quite patent stent, and we were very happy. But then we wanted to do an OCT to see what's really happened. So we did an OCT, and this was a run at 9 months follow-up of a bimetal stent. And clearly the stent was well endothelialized and healed. There was some amount of excessive neointimal proliferation distally, but you could see that the stent, we could not see any positive remodeling there with well-covered stents everywhere throughout.
It just shows her reaction, right? This is an excessively hyperplastic response. So all of her reactions are exaggerated biologically. So it fits with the overall milieu of this patient.
I was just going to comment that I think that was a fairly intelligent thought process. You transferred a drug-induced stroke polymer-induced reaction to a neointimal hyperplasia, which is what happens with bare metal stent, and you therefore caused fibrosis rather than lumen enlargement. You shrunk the lumen as a healing process for that totally expanded vessel. So I think that was a great idea. It was a thought process which is unusual, but it actually worked because you created fibrosis rather than a positive remodeling.
So to be balanced, one comment. We try in many of these patients everything, including bare metal stents. Many times it was working, sometimes it's not working. And so I'm not sure, I'm not guaranteed by the fact that this is only one solution for trying in this patient. You may try, but sometimes it was not working and the process was continuing. We also try drug-eluting balloon in some of these patients. We try to speed up the neointima by using bare metal. We try to use also drug-eluting balloon, but the results were quite sparse in terms of response.
Giulio,
my thought process would be not to deliver more drugs. Here, you just got a few options. Either oppose the stent and keep the patient on a single antiplatelet along with anticoagulation, or you try and close that. If it's too huge, if it's aneurysmal, you have covered stents. And if it's not, create neointimal hyperplasia and fibrosis to try and seal up those areas. And I think he managed that.
I think the same question I was going to ask. Giulio, polymer versus drug. What do we think is the more biologically reactive substance? Do we know?
Well, many of these patients develop this type of reaction in the mid-long term. And so sometimes you have, so for the first case of the hypersensitivity, it was in Ravel. And Ravel had a serious IVUS evaluation. And at 6 months, the patient was perfectly still in terms of IVUS response. And developed this type of response 18 months later, while the drug was gone in a short period of time. So this is what I'm thinking, and when it was analyzed pathologically, histologically, we discovered a lot of inflammation with a distortion and the destruction of the vessel wall by this inflammatory process.
Thank you. Then I would also like to point out the usefulness of OCT in assessing stent healing. I think which was really helpful here, as well as there are some areas where we can even use OCT, particularly in the first generation drug-eluting stent, to decide on whether to continue DAPT. OCT may be useful to find out whether we have a good healed stent. So to conclude, I think what we learned from this case is this is a clear case of a late stent malapposition, acute malapposition, and it is multivessel. So the presentation was a recurrent multivessel stent thrombosis, and the critical role of imaging, I think, identified what was a real problem. And here, really, both OCT and IOS was extremely useful. And IOS is some technology where we are clearly identifying the positive remodeling as opposed to OCT. And in fact, the right coronary artery, in spite of being normal angiographically, imaging did help us to identify the positive remodeling. And the bare metal stent was a rescue in this case and shown to heal rapidly and solve this recurring problem. So to summary, intracoronary imaging is very useful in evaluation of stent thrombosis, and OCT for most, and IVUS in some of the cases. And it's important to identify the mechanism and evaluate and differentiate the cause, exact cause, and then the target the specific treatment to achieve the best results. Thank you.